really the goal is just to use our stories to bring veterinary medicine to life for the pet caretakers of the world. And we're doing it because we believe that educating these caretakers is the most powerful thing that we can do to improve the life quality of all of the pets that we love. Hello. It's Vet Tales. Dr. Natalie Keith.
Dr. Josiah Dame.
And today is all about the adrenal gland. You know what? It's this tiny, tiny, tiny little organ. There's two of them. It's a pair. And they are just nothing but trouble.
Can't live with them.
Can't
live without them.
I mean, yeah, you can live with them as long as they're cooperating.
Oh, yeah.
But they have some fall apart moments in either way. Like they can overswing or underswing. And so we're going to talk about those two diseases today. If the adrenal gland is either over or under reactive.
Mm-hmm.
So I think that I guess we could name them too. We'll name them both, and then we'll take the easy one, easy one first.
Yes. So we got Cushing's disease and Addison's.
Uh-huh.
I feel like a lot of people heard about Cushing's disease.
It's like when I first started practicing, people were like, "What?"
Mm-hmm.
But now people will, because of Google, I think they'll be like, "Do you think my dog has Cushing's?"
Potentially.
Yeah. Potentially. Yeah. Hyperactivity.
Yes.
Is Cushing.
So Cushing's disease, just jump right in.
Yeah, do it.
Cushing disease. So it is where the body is over making cortisol. And so there's a couple ways that can be happening. That can be a pituitary dependent tumor or an adrenal dependent tumor. Essentially saying there's either overgrowth or a tumor growth on the pituitary gland that's sending too much signaling hormone, or there is a functional tumor on the adrenal gland itself that is producing too much cortisol. Because essentially your pituitary gland, when you get stressed out, nothing about
what?
It tells your body, oh, well, release some cortisol because you need that.
Yeah, cortisol will keep you alive in a time of stress.
Yes. And so then it goes all the way to your adrenal glands, which is down near your kidneys. And then it starts to produce this cortisol. And it's super important. You just don't want too much of it.
Yeah.
And then you can also, like I was saying, a tumor on the actual adrenal gland, that's just down. Pump out cortisol and you don't really need it. And then you're like, well, shoot.
Yeah.
So these Cushing's dogs, they're very common. They can come in textbook, they can come in not. But very commonly, they're going to be panting.
Mm-hmm.
They're going to have a potbelly appearance because cortisol makes you lose your muscle mass. So they're going to get a thinning of their abdominal wall.
Which makes their tummy sag.
Yeah. And those dachshunds with those big tummies that are panting constantly, their skin will thin out.
Mm-hmm.
They can get something called calcinosis cutis, which is not cute. It's
these little white, kind of pimply looking thing. Like they're just like little white flecks and they're hard. Yeah.
It's awful. And then you can get peeing and drinking more often, which is one of the most common reasons people come in, because they can handle the panting, they can handle the big belly, but they can't handle peeing and drinking more.
Yeah.
Just anxious and just like.
Well, I mean, just think about like
stress.
Literally, I mean, they have a physiological reason instead of like us. We typically have mental reasons for chronic stress. Like you're studying for a big test, you're stressed about it, your cortisol temporarily goes up. But if you're living in a state of chronic stress, which we won't go into because it's not a therapy podcast, you have this whole different effect on your system. And so these dogs are like, we are doing it maybe from an emotional reason, but these dogs are doing it because their body is telling them, hey, you're stressed. Hey, you're stressed. Hey, you're stressed. And so they're behaving as if they're stressed, even though they don't really know why they're acting that way, because it's the same effect, because either way, cortisol has been released.
So yeah, these dogs come in, you lab work.
Yeah.
What's the most common lab work changes we see on a just routine?
Yeah. So that your first screening is going to be looking for elevated liver enzymes. Yeah. And their livers a lot of times will be pretty darn big, like physically, as far as like an ultrasound or something like that.
And then the particular value that's always higher is going to be ALP on average.
Or alk phos or alkaline phosphatase, if we want to get all the way out there. But we call it ALP.
ALP. And then ALT, which is the other liver value, will be slightly elevated typically, but not like
dramatic.
Yeah. And then I get that lab work back and I go, okay, I think we have Cushing's.
Yeah.
Now that's not the end of the road. Now we need to do something called the low dose dexapression test, which is basically giving a steroid to your dog and seeing if their body reacts to it appropriately.
Right, because cortisol is a type of steroid. It's just, one that our body makes naturally versus a artificial, artificially administered steroid. But we're mimicking a stress event by giving them this steroid, and you're looking to see what does the adrenal gland do with that information.
Yeah. Does it calm down? Does it say, oh, there's more steroid here, let's chill out, let's not produce as much? Or does it just keep going?
Yeah, and then the numbers just skyrocket because it's like, yes, more steroids because we're more stressed. and cortisol just goes up.
And so that test will allow us to diagnose the actual Cushing's disease officially. And sometimes it can even help you, assist you in finding out, is this adrenal dependent or is this pituitary?
Yeah.
Interesting, because without doing advanced imaging, we're not going to see the pituitary tumor. Some ultrasounds will find the adrenal tumor sometimes. So it is a nice test to do. And then we got our diagnosis. It's not the end of the road. So,
yeah, so sorry.
So sorry. Next step is to start treatment in general,
which is going to be both symptomatic and based off of lab findings on rechecks.
Yep.
So it's complicated.
It is complicated. The gold standard treatment is going to be Veteral.
Yeah.
Or Trilostane.
Back in the day, what was it that we used? Mitotane. And it was like, it fried their adrenal glands. Yeah, because basically what both of these drugs are doing is stripping down layers of the adrenal gland on the level that is secreting the cortisol. Because either way, whether it's an adrenal gland tumor or it's from the pituitary, either way, your adrenal glands are like jacked.
Yeah.
And they're just like these massive adrenal glands that are just pumping things out. And so we need to strip them down a little bit.
Which Trilostane is relatively minimal on the side effects for the most part.
And I think with the mitotane, there was like an issue with bald eagles. It was like some kind of like, it's before you time older than Josiah, as we all know. But anyway, or at least he and I know. There was like something about in the dog's urine, it was excreting it into the environment and it was like getting into water. I don't know, somebody needs to Google this, but something about bald eagles. So
is it the thinning shell?
I
thought that was the pesticide.
I don't know. We may have to follow up on this. But anyway, something about environmental contamination, but Trilostane, we don't have that issue.
Yes. And the thing with Trilostane is you have to monitor it.
Yeah.
So we'll start it 2 weeks, 4 weeks later, in between there, 3 weeks, let's say.
I like that.
Cut the middle. We typically will do something called an ACTH stimulation test, another kind of stress test on the adrenal glands.
Yeah.
Where we give a medication, which I struggle to say for the life of me, Cortisone.
Yeah. Which is, synthetic cortisol.
Yeah. And we see how the body responds again. Why do we do that? Because you can't overdo it on Trilostane because you'll cause the opposite, which we'll talk about later, which is Addisons.
Yeah.
And so we
you've overstripped the adrenal gland.
And you also want to strip appropriately. So you want to make sure that you're taking enough of the overproduction away so that you're actually getting resolution of clinical signs, but you don't want to take too much where you're causing, again, the opposite, which is Addisons.
Yes, absolutely.
Most of the time, we haven't increased the dose enough. And once we get to a nice range, we start to see resolution of some of the clinical signs. We will stay steady, and then we'll just recheck every 6 months. Calcinosis cutis takes the longest to recover, but it will recover.
Yeah. And it does. Once you get them set on the right dose, they are usually pretty steady.
Yeah, they do a really good job.
Unlike diabetic scur.
Yeah, that is slow. I much prefer Cushing's disease.
No joke.
The problem is sometimes Cushing's and diabetes come hand in hand.
Yeah.
And that's never fun.
It is not ever fun.
No.
Yeah.
There's some other treatments, technically.
Oh yeah. Let's do that.
Cushing's disease.
Yes.
So we have Trilostane, but Tennessee University, who does a lot of research on Cushing's disease in particular, and they've put out some treatment plans. There are some holistic, in quotations, kind of treatment options with melatonin and lignin husks that decrease the estradiol levels, which then in turn decreases your cortisol levels. It is very much tough to monitor other than the clinical signs. If it's helping, it could take up to 4 to 6 months to even see a change. So it's not going to be as immediate as trilostane. And most of the time when dogs are coming in with us with Cushing's disease, they're in a state of severe
clinical. Yeah.
So
I also like it though, like when I have a dog that looks and acts like Cushing's, but my low-dose dex is not consistent with Cushing's, I will use that approach because it's like no harm, no foul. It's like not going to hurt anything to try it. Maybe we make some improvements, but I can't legitimately justify doing trilostane, you know? And so, but you got to do something for these dogs that exhibit it, because Cushing's is one of those diseases that the tests are complicated, the tests are gray, and the clinical symptoms can vary. And so it's never like this. It's not like a pregnancy test where it's like yes or no. This is, everything seems to be pointing that way.
Yep.
So let's.
Yeah. I mean, I've done every test on a dog before once, and I was like, I can't find out why you're PVD and panting, but I bet it's Cushing's disease. You look Cushionoid. Sent it to the specialist. They did the low-dose expression test. They did the extended panel through Tennessee University, and they were like, no, not Cushing's yet, but probably in 6 months.
Yeah, that's the thing.
They'll always say, recheck that low-dose expression test.
Yeah, it's like hyperthyroid cats. Just give it a second.
Yeah, give me a second. And then I'm like, well, they're clinical now, but I can't start trilostane. So sometimes, yeah, you can reach for, melatonin is not going to hurt.
Yeah. Yay for melatonin.
A lot of dogs on melatonin for hair loss and things like that. So, yeah. And I've had some dogs who were very mildly clinical, but we ended up diagnosing them because of the ALP elevation. But other than maybe a little bit of panting, they didn't have many other clinical signs. And they are true positives. I was like, let's just try, melatonin Langenputzke and see how we do. Instead of jumping to trilostane because the owner wasn't ready and the dog was.
Also, I just want to say trilostane's expensive too, and melatonin is dirt cheap.
Again, you're not going to get the same results if you're not super.
But it beats a poke in the eye if you got to do something, especially if the owner's like not really sure they feel okay about the drug, or all these other things that just don't swing you super hard in that direction. It's just a nice middle ground.
Yeah. So that is
I know. I was like, oh no, this is the end, isn't it? We're going to have to talk about the other disease. God, help.
Any other things about me?
Yeah,
I can't really think of it.
I don't think I can stop much longer.
I did my spiel.
Yeah.
I like Cushing's.
Cushing's is nice, yeah. And it's more common than...
Very common.
It's very common. I think when I was in school, they were like, don't forget to think about Cushing's. Like it was maybe like an outlier.
I see dogs in the
waiting
room and I'm like,
yes.
You're not just a fat dachshund.
No, 100%.
You don't have abdominal muscle.
Yeah.
Oh, yeah.
I love the walk-by diagnoses of things like that.
Yeah.
Dr. Greg and I were talking about that with bladder cancer yesterday. She was like, because it's got a distinct smell. And she was at this, she was working in a different state, and the dog comes in and it's not her case. Another doctor's working on it. And as she walks by and she's like, oh, that's bladder cancer. And she's like, what? She goes, it smells like bladder cancer. She's like, you can't diagnose bladder cancer with the smell. And she's like, yes, you can. Sure enough. Yeah. So I think sometimes people, especially I think we can get in a hurry and not always say out loud all the things that is happening in our brain on this 5-second walk by exam, that where our brains have already solved the problem, and all we need now is the proof.
Yeah.
So
I think you and Caitlin just have a really good sense of smell.
That could be, yeah. So then we went through the list yesterday of all the diseases we can diagnose by smell.
Aren't there Labrador retrievers that can diagnose cancer?
Dude, and beagles. I think, yeah. I'm definitely not a dog.
I'm not calling you a dog.
Anyway, all right. That's it. We have to do it.
Yep.
Okay, so the other end of the spectrum is Addisons, which is adrenocorticism. Wildly more complicated.
Much more complicated. To kick off with Addisons, let's approach it like it's a dog kind.
Okay, I love that idea.
throw out everything you know. No, I'm kidding.
Yeah,
So
the great mimicker, right?
Yeah, it can mimic things. And so let's break it down this way. There's two types of Addison's cases. There's going to be typical, which you cross your fingers and hope that it is typical. And then you have eight.
Which is just really just a rude slap on the back of the head every single time.
It's not fun when it's atypical. So typical, I had a case. He was a vet tail. It was last summer. I had a 80-pound, which this is not the typical patient. The typical patient for Addison's is going to be a female, 5 years
5 to
old,
7, chronic waxing and waning diarrhea,
vomiting, and just like long-term signs.
Yeah.
And then come in just dehydrated and feeling terrible. I had a 5 or 6-year-old lab male who came in for 1 day of vomiting and diarrhea. Because it was typical, I did the lab work and there was electrolyte abnormalities. So typical changes in the typical Addisonian, you're going to get a really high potassium and a low sodium.
Mm-hmm.
And then you'll have a sodium potassium ratio that's below 4.27 or whatever. And that is a great, just like slap.
Yeah. Hyperkalemia. You're like, oh, thank goodness.
Yeah. So you see all those electrolyte abnormalities. You're like, oh, wow, whoa. We have Addison's.
Yeah.
Which is the lack of production of cortisol.
Yes.
And then you immediately put them onto fluids and you immediately give them steroids.
Yep. Because
you're replacing what their body is not making, because if they don't get that, they will go into shock and die. Now, the choice of steroid when you initially start treatment is very interesting, because even though that lab work in typical, you're like, boom, slam dunk. That is Addison's disease. You still want to confirm it. We confirm it with the ACTH stimulation. So we'll typically do an injectable steroid called DexSP, because it does not skew that test. We'll start that test, and then you will start oral steroids and then percortin injections from there to hopefully get them off of an oral steroid and just do monthly injections for management.
Yeah, literally monthly injections for life.
For life. And then typically we'll also tell the owners, here's a bottle of prednisone. If you have a stress event, if you go out of town, do a low dose, because physiologic dose, so just super small, below what you would get for, like me right now, who's on a steroid. Yeah. Because my skin is very mad at me. I am on an oral steroid and I'm feeling the effects, but it's minute dose.
Yeah. Basically, anytime that your body should be producing more cortisol, because again, you're studying for an exam that's a big deal, or whatever, their body's not able to mount that extra amount of cortisol, and then the body will kind of crash, because the cortisol is imperative for functioning in a time of stress.
Yes, exactly.
So,
and then there's atypical.
Well, and I feel like, I don't know, like before we move to atypical, because I feel like typical, you can still get thrown for a loop, because a lot of times they'll come in like a kidney disease. I can think of a vet tail of this little, it wasn't my case originally. Dr. Trussell had taken him in, teeny tiny little Yorkie named Rocky. And he had a couple of things that were interesting. He had this head tilt that was like kind of like neurologic, like almost vestibular, don't know, question mark, what's going on there. And then his kidney values were through the roof, and he didn't feel good, and he had waxing and waning diarrhea, and you're like, okay, well, that makes sense for chronic renal failure. But it was weird because he wasn't that old.
Yeah,
he was only like 6 or 7. I was like, why is this dog in chronic renal failure, or even acute renal failure, and what's up with this head tilt?
Yeah.
And so essentially all of a sudden this little light bulb goes off in my head. I think because, to be honest, what it was that I was like, he's got I don't know, I feel like he needs a steroid. I gave him a steroid, and boom, the dog pops back to life like a little daisy that got watered. And I was like, smokes, this is Addison's. So we send off the cortisol levels, and sure enough, that's what we're working with. And then so we start all the percortin and whatever. But it's so easy to think that you just have a gastroenteritis or a renal issue, especially if they don't give you that hyperkalemia on their blood work.
Yep. And because harkening back to you, by the time I see a dog 2-3 times with diarrhea, I start to go, hey, can we send off, you don't have to send off a full ACTH stim right away.
Yeah, you can just do a baseline cortisol.
And so if I have like a 1-year-old, 2-year-old dog who's like coming in for the 4th time with diarrhea that we've seen them, I'm like, hey, let's send off a baseline cortisol.
Yep.
Let's just hope that it's really high.
Yeah.
If it's low, we'll do the confirmation test, but hopefully it's normal. And 99% of the time it is normal.
Yeah.
But yeah.
But if it's below 0.2, then you're like, I got you.
Yeah. Yeah, exactly.
So, okay, now atypical.
Yeah, so atypical. Again, Addisons, they can present in any which way that they want to present. Atypical is frustrating because you're not going to get the electrolyte changes.
Yep.
And so majority of general practices do not have cortisol, an ability to run cortisol within the clinic.
Yep.
So majority of general practices aren't running that versus like an ER that does have it in-house.
Yeah, it's just part of their routine. Like we just run everything and the cortisol is part of that.
And it is not for us. So we may do the lab work. It may be normal. The dog is, sick with, say it's GI signs. We start fluids and everything. It may not be the first thing that comes to mind or the first thing that comes to, testing options when you don't have this classical presentation or 2 classical blood work changes.
Right. And I think it's also important just from a perspective standpoint to say we see dogs with diarrhea and GI signs like 8 times a day. And it's like maybe 3 times a year that they're Addisons. Yeah. So I think the line that we walk, especially as GPs, is like, it's hard because you can't have every dog that walks in with diarrhea, you can't be like, let's run full blood and a baseline cortisol and da-da-da-da-da-da. And the owners are just like, hey, it just has the runs. Can I just get some probiotics? Just stop the insanity. And, because it's not practical.
Yeah.
It's not like every time you hear hoofbeats, if you're like, it's probably a zebra, you're going to be wrong like 99.9% of the time. So that's the line that we walk as GPs, although it would be great because then we look like dum-dums whenever the dog comes in and it's like, man, it's not getting better. They go to the ER and they run the baseline cortisol and look like a hero because they figured it out. And it's like, no, they just run $4,000 worth of diagnostics when you walk in and we only had $150 on your budget. So that's a little bit of just like backstory of how GPs get busted on this Addison thing is because we just don't have it typically in the budget with most clients to run all of these tests every time a dog walks in with diarrhea.
Yeah. And we have to weigh again, cortisol is not something that it's a send out test. So it doesn't go out right away. It would go out, the next day and then we would get results a day or 2 later. So it's definitely a struggle of that delay of testing too. Again, we do send those out. We do diagnose Addisons, but when it's atypical, it can be tough because until okay, we aren't getting better. Okay, well then I need to dig deeper into my diagnostic tree and say, okay, the next thing would probably be a baseline cortisol. So we need to do that. And in the meantime, I'm going to give a DexSP injection just in case this is what's going on, because then we're covered, but it won't ruin anything if we need to run.
Absolutely. Which is a great little bonus that you can kind of walk that line that way by giving the DexSP.
Exactly. And so, because you want to get a diagnosis before you start a steroid like prednisone, because you do that test from there on. But hopefully, we will get in-house cortisol testing at some point.
I know. It's on the wish list.
It's on the wish list. There are companies that do have it, obviously, but the particular systems we have, they are talking about.
Yeah. So hopefully in the next year or 2. Who knows? In the meantime, it's just you do your best and try to keep your eye out for it. Try to be open-minded about Addisons, even though, again, we're only seeing it a few times. But I feel like we've had like 3 this year already.
Yeah, we've had it.
Because I had that one with the hypoglycemia.
Dr. Keith had one. Dr. Greg had one. I have not had one since last year.
Okay, so
maybe I have sent off a lot of baselines.
And they were all fine.
And they were all fine.
So you had one last year. And then Dr. Greg and I both had one this year. Yeah. How did Dr. Greg's come in? I can't remember.
It was acute vomiting. There was no historical changes, and there was a history of potentially eating something.
Yeah, I was going to say, the list of acute vomiting potential rule outs is like 159.
And it did not fit the classic presentation, like signal met, which means like age, breed, gender. And so Yeah, it was, x-rays were taken and then, went home, didn't respond to the treatment, like this typical treatment that we would do for a vomiting dog when x-rays would relatively normal. So then they went to the ER and it was with the cortisol test there.
Yep. Yeah, we need one of those so bad. Anyway, so we get a diagnosis of Addisons, and then literally it is a lifelong management like we talked about with those every 4-week injections. Percortin is what we use. And what I typically will do is once we have this Addison diagnosis, then we start at I usually start around day 21 post giving the shot. Oh, this is when they very first get diagnosed. Day 21, I will check electrolytes. Now, this only works for a typical Addisons. It doesn't for atypical. And then you look to see when do these electrolytes start to get weird, because it could be anywhere between day 21 and maybe day 32. And once you get a feel for that, then you're okay, you're on, most typical is a 28-day cycle. And then we monitor them a little closer, especially initially in those first few months. And then usually it's pretty smooth sailing. I had one dog named Toto. He was a typical Addison that presented as a renal failure initially with a long history of waxing wing diarrhea. So he was pretty easy to catch, but the owner would be oh, he's fine. He's better now. And so then he would come back in another Addisonian crisis. And then I'd be all right, so he does look so good on his medicine, which is amazing. And I'm so glad that he feels good on it. However, if we don't show up every 28 days, then by day 60, he's going to be in the hospital again, and we may not pull it through. Finally, after about the third round of that, the owner was on board, and we never missed another shot. And that dog lived for years until he was super old. Yeah.
They use super well if you catch it and you manage it. But I mean, Percortin is expensive. Definitely when you have an 80-pound dog.
Yeah.
My recent one that's getting 2 mils every 28 days, 2.2 mils, 2 mils every 28 days. Crazy.
Yeah.
But he's managed well.
Yeah. Luckily, the little ones though, it's when they're getting 0.2 mils.
Exactly.
It's not a big deal. Different. Yeah. But that's the thing about big dogs. So they just take more medicine.
More medicine, they're expensive.
They are. Oh my gosh. Yeah.
That's Cushing's and Addison.
That's Cushing's and Addison. There's nothing to it. Just these teeny tiny little peanut shaped glands sitting right next to the kidney.
Listen, I know it. Been on that wheel stair now. I'm I know a lot.
Let me tell you about adrenal gland function. Oh, I hate being on steroids. But sometimes you got to do it. Yeah. Anyway.
Vitamin D.
Yes, exactly. Oh, man. Okay, cool. So that's all we have for today. Hopefully this was helpful for you. If you just had a patient diagnosed with this, and this is why you're listening to this podcast, is because we told you should. If you still have questions, call us anytime. And it's just, it's a management game, but we got you. So, all right, cool. Till next time.
Till next time.
Okay, bye.
Bye.